Hello, everybody. I'd like to welcome you to this session on acute and hospital care, and think we will have a very interesting session with 4 presenters from 4 countries this morning. My name is Sabine Jansen. I'm the Executive Director of the German Alzheimer Association. I just want to make sure that you know about the chat function. We will have 4 presenters. 3 are pre-recorded and 1 presenter will be live with us, but all of them will be here to answer your questions. So please feel free to use the chat room to send your comments, ask questions, and we will try to answer all the questions in the time we have up from now. First, I'd like to introduce our first speaker. He's Vincent GALIBERT. I try to speak it in French because he's from France, and his theme is the Village Landais, a new innovating and caring structure in the southwest of France. Vincent or Vincent, the floor is yours.
Hi everyone, I am very happy to be a part of this event, and I just regret that we cannot meet in person to speak about our commitment towards Alzheimer's people and their close ones. Allow me to introduce myself. I am Vincent GALIBERT, Director of the Groupement of Public Interest Village Landais Alzheimer, which is a new structure located in Dax in the southwest of France. The village opened in June 2020. So right now we are taking care of 105 people with dementia in a 5 hectares area. My presentation will last approximately 10 minutes so that we can have some time for questions and answers, as I understood. So first I will tell you about the genesis of the project, and then I will describe its main features. So just to remind you that in France, the number of cases of Alzheimer's type dementia is estimated at 1 million, with 225,000 new cases every year. The number of sufferers will exceed 2 million by 2040. In the land, there are estimated 8,000 people with Alzheimer's and similar diseases. So just for the context, you have to know that in Land, all retirement homes are public, and many of them have protected units for people with dementia. On average, it can hold between 10 and 12 people with Alzheimer's disease or related diseases. In France, like in several countries in Europe and across the world, politics and administration agree on the fact that dementia, especially Alzheimer's disease, represents a major issue in global health policies. With the behalf that we could find another way to take care of elderly with Alzheimer's, former president of the Department of Land, Henri Emmanueli, found in an article of the newspaper Le Monde the inspiration for an innovative project. He read about the Orgewek, a Dutch village close to Amsterdam that aimed to maintain cognitive and physical capacities for people with dementia, while volunteers and families teamed up with professionals to take care of them. He decided he wanted to put Lens forward as a pilot department for the care of people with Alzheimer's and other related diseases, and asked to realize and inspire structure here. So to speak more precisely about the project, it has so many features that I will try to expose everything without taking too long and not forget anything. So first I wanted to talk about the architecture. The village is inspired by the traditional architecture of the London and is run like a real village in which villagers enjoy considerable freedom of movement. The French-Danish project management team imagined a village whose life revolves around the central venue, the Bastide. It is how the central square of a village is named in London. From a technical point of view, the shapes, materials, and equipment were chosen to favor natural light and ensure sustainability, as well as being simple, progressive, and economical to operate. The Bastide is the heart of the village. so the main square. It offers meeting places and services, including a restaurant, a multimedia library, an auditorium, a medical center, 9 studios for caregivers, interns, and professionals, a convenience store, and a hairdressers. Most of these places will be open to the outside, meaning that any inhabitant of that city or above could enter and wander around freely. There are 4 neighborhoods, each with 4 homes spread over a wooded environment of more than 5 hectares to house 120 future villagers. 7 or 8 residents will live in each of the 16 homes, measuring 300 square meters, and it's inspired by the traditional land architecture, the same colors, same materials, and local tree species. Each home has been designed to respect the various lifestyle of the villager, but also their independence and privacy, because they all have their own room. In the 5 hectares of landscaped grounds, residents who wishes to do so can indulge their passion for gardening in the shared vegetable garden or look after the animals in the mini farm. So second, I wanted to speak to you about the medical approach. The village will be a new facility where people suffering for Alzheimer's disease will go on living like at home. It's very important. One of the goals is to gather the quality of life of a stay-at-home policy for elderly people and to struggle against isolation provided by collective structures. In fact, the shape of small houses units is, according to us, the best solution we found to combine those positive effects. The structure offers person-centered support and non-pharmacological approach. By that, I don't mean that it won't be used for medical issues, but that will be used only if necessary. We hope that an active social life and the development of a person-centered and like-at-home policies will help reducing the remedy of drugs. In concrete terms, we aim to maintain a maximum of daily references for the person and maintain social ties, thanks to the involvement of our volunteers and the fact that the place given to families will be paramount. To sum up, our goal is to preserve as far as possible the cognitive and practical abilities of our villagers. In order to complete this non-pharmacological approach, the project is trying to get the environment as neutral as possible. That's why there is no visible white coats. Our nurses, caregivers, and doctors are dressed as in everyday life. Approximately 120 professionals are working in the village right now. There are always at least 2 persons in each house to take care of villagers. We also have a presence at night to prevent any incidents. So as you know, people with Alzheimer's often roam at night, but also at day too. Within our population of 120 villagers that we will welcome soon, we are also welcoming 10 people under 60 years old. It was a very important part of the project because it is very hard for them and their families to find solutions in public or private structures when staying at home is not possible anymore. So beyond our 10 youngest villagers, our project welcomes also many young Alzheimer's people between 60 and 70 years old. And just so you know, our youngest villager is 38 years old. Our oldest is 100. Third, I wanted to speak to you about our scientific projects and our resource centers. The village is an experimentation. It will last at least 5 years, and the team of scientists from Bordeaux University will be in charge of setting up a protocol for assessing the people suffering from Alzheimer who live there, but also caregivers, family, and volunteers, in order to evaluate the exemplary nature of this innovation and develop research that will make it possible to say it brings good to the health of these people and this setting deserves to be extended elsewhere. The promoters of the village have, from the beginning, wanted research to be associated with this innovation. So we will conduct research inside the village with other researchers to study mobility, motor skills, the impact of new technologies too, new forms of rehabilitation, of connecting loves, and perhaps in the longer term, the impact of certain drugs. The village will also be a resource center for medical and therapeutic research. This is an essential part of the project. Several evaluation studies will be conducted to measure the exemplary and effective nature of this innovative management method. A study will also focus on the impact of new technologies and new forms of cognitive impairment rehabilitation. All the medical and medical social actors, as well as the carers, will be able to find additional support of new model of cares there. And finally, I just wanted to speak to you about our partnerships. So if we walk a long path since the beginning of the project, it is mostly thanks to our numerous partners, especially in our local areas. So we had from the start the support of local authorities like Dax City and Dax Agglomeration, also the Department of Land and the local branch of the Regional Health Agency, which is a structure from the states and the government. We're also very grateful to private partners, associations like France Alzheimer or the French Mutuality that we had a health center within the village. And finally, we aspire to build strong and long-term partnerships with European colleagues and contribute to spread the philosophy carrying us for Alzheimer's people across Europe. So thank you very much for listening. I hope this has interested you, and I am available to answer any questions right there or by email.
Thank you very much, Vincent, about this interesting, the report about this very interesting project. There's already one question coming from Wendy. And she's asking if people with dementia live there with their partners, and if so, how is this different than a retirement community? Can you answer the question of Wendy, please?
I can answer the first part. First, thank you very much. I won't say it in person, so thank you very much for inviting me in this conference, and thank you very much for your attention. We are not welcoming couples unless they both have dementia. And right now in the village, we have two couples with Alzheimer's disease. And they each have one room, and they have the choice if they want to stay in the same room at night or if they want to be separated. We only can afford to welcome couples in these situations.
Okay, thank you. If you have more questions, please use the chat. So far, I have a question to you. You told us that some of the services are open for the neighborhood and for the outside. How do you deal now in the COVID-19 pandemic? Is it still open to the neighborhood, or did you have to close the village?
The chance we have about the COVID-19 situation is that we were supposed to open in April the 2nd, and just to give you some context about the pandemic situation in France, we had to confine everybody the 17th of March, so 15 days before. So we had to postpone the opening of the village, and we had our first villagers in June. So we decided with the authorities, the sanitary and local authorities, to postpone the opening to the outside. So first we wanted to do it in September. As you know, it's not possible. So right now, these equipments are only open for villagers. We still have volunteers intervening in the village. So we are very happy to have managed to have them with us. They arrived in July, and we cannot know right now when we will be open for the outside. But just to reassure you, we still have families coming, we still have volunteers coming. So right now we are in not that situation that we could be in June or in April.
So you couldn't make any experiences in this field yet? Yeah.
No, and we are very frustrated not to open.
I can imagine.
everyone.
And do you have a discussion in France? Because we have it in Germany. That's the discussion if a special village like your project, we have maybe similar in Germany, a discussion if it's good to have this segregation of people versus inclusion, because everybody's discussing about inclusion. Now we have a very special village for only people with dementia. Do you have this discussion in France too?
Yes, of course. And in France, the culture about welcoming people with dementia is not too sorry for the expression, to imprison them, because the model is mostly based on the sanitary conception. So in the village, we want to have a space of freedom inside the village. And so this is first step. And second step is how you can give freedom to those people by going outside and having a lot of people coming to them, even if it's not especially to interact with them. So of course we have this debate. In France, it's mostly between security and freedom about people that are living in structures like ours.
Mm-hmm. Yes, thank you. There's just a raised question from your audience, or from Catriona. She asked concerning the research and the evaluation, if you also plan to measure the quality of life. That's also most important to people with dementia and carers, but it's not always measured. Do you have to plan to measure quality of life in your research you will do?
Yes, of course, we will have two ways to do that. I think there is first the research methodology that I spoke about in my presentation, with a lot of criteria to evaluate how much the village have an impact on the welfare of our villagers, but also their close one, because it's very important to measure this. And as we are launching the project since 2 or 3 months, so we need to stabilize everything. But my colleagues are also working on a quality approach to ask questions about how it is going in the village, because we are in experimentation. So we are not saying we are the model and we are this solution. We are saying we are trying to do something a bit different. And we have to question every time if we are doing it the good or the wrong way. But first we have to define what is good and what is wrong way. So this is very interesting for us to have this these exchanges with partners in France and partners in Europe and across the world, because we can compare what everyone is thinking as a good or a bad intervention towards people with dementia.
Okay, thank you very much, Vincent. People looking forward to a publication of this question. Thank you very much for your speech, and I also like to thank you for the questions so far. And now I want to go to our next speaker. It was foreseen that Ioana should speak now, but she has not yet arrived in this session. So we go forward to the speech of Helen Skinner and Matilda McCrimmon. They are both from Scotland. Both are Alzheimer Scotland dementia nurse consultants and have a lot of years of nursing experience. Helen's research interest is in the use of personalized music to support people with dementia, and she recently completed a study exploring the use of individualized music in the management of agitation in people with moderate to severe dementia. She's also currently the chair of the National Alzheimer Scotland Dementia Nurse Consultant Group. So very long title. Helen, we look forward to hear your speech, and also Matilda, welcome to the session. And I think this presentation, it's pre-recorded too. And now we hear it. Welcome.
Thank you for the opportunity to present today. My name is Helen Skinner and I am the Alzheimer Scotland Dementia Nurse Consultant in NHS 5 in Scotland. And today I am presenting with my colleague Tilda McCrimmon, who is the Alzheimer Scotland Lead Nurse for Dementia at NHS 24 and NHS Golden Jubilee Hospital in Scotland. Our presentation today will describe the journey of the Alzheimer Scotland Dementia Nurse Consultant role over the last 10 years, highlighting the partnership between Alzheimer Scotland, Scottish Government and the NHS Health Boards in Scotland. This presentation will also highlight the value of a specific dementia nurse working in NHS 24 emergency and crisis care. In 2010, Alzheimer Scotland launched a Dementia Nurse Appeal, which attracted funding from Scottish Government. By the end of 2012, funding for a Dementia Nurse Consultant was available to each territorial health board in Scotland. Initially, the posts were fully funded by Alzheimer Scotland and Scottish Government, but since 2015, the posts are predominantly funded by the individual health board, but still with a contribution from Alzheimer Scotland and Scottish Government. This map identifies the territorial health boards across Scotland. Each health board has a dementia nurse consultant or a dementia lead nurse who works locally to drive improvement in dementia care. But the role also has a national remit, and all the Alzheimer Scotland dementia nurse consultants and lead nurses meet and work collectively on national projects. This collective power results in a group of individuals who can influence, inspire, innovate, and improve practice across the whole of the country, supporting the ambitions of Alzheimer Scotland and also the strategic drivers of Scottish Government. This slide demonstrates the multifaceted nature of the nurse consultant post. Expert practice is a key element of the role. Consultants work with multidisciplinary teams across organisational, professional and agency boundaries and possess a high degree of personal and professional autonomy in making complex clinical decisions. Professional leadership and consultancy is demonstrated by nurse consultants contributing to national and local developments in the field of dementia. Policy and service development, research and evaluation is another important element of the nurse consultant role. This involves the development and implementation of key policies and recommendations which may lead to service redesign and introducing new models of care. Nurse consultants also ensure new ways of working are evidence-based and person-centred. This may be through analysing, synthesising and interpreting evidence to underpin practice, or by undertaking their own research or collaborating with research partners. And finally, the education and the professional development role of the nurse consultant promotes and facilitates positive learning environments and influences the strategic development of organisational learning to enhance the patient's experience of care. The key drivers that influence the work of the Alzheimer Scotland Dementia Nurse Consultant include the national dementia strategies in Scotland, the standards of care for dementia in Scotland, and promoting excellence, which is the knowledge and skills framework for health and social care staff working in Scotland. But an important driver has been the 10 dementia care actions in hospital, which were launched in Scotland's second national dementia strategy in 2013. All NHS boards across Scotland are committed to continuous improvement across the 10 dementia care actions, and these actions drive the work of the nurse consultant. Across Scotland, we have dementia champions and dementia specialist improvement leads who are key working relationships for the nurse consultant. A dementia champion or a dementia improvement leader is a member of the healthcare team who has undertaken a national programme of study. They strive to improve the experience, care and treatment and outcomes for people with dementia. They promote person-centred care, lead and support change in care practices, and provide advice, guidance, and support to colleagues. The nurse consultants work closely with the champions and the improvement leaders, and collectively they became a force within the healthcare setting to drive improvement. In 2019, the nurse consultants launched a report that highlighted some key achievements of our work and identified priorities for the coming year. This report is available on the Alzheimer Scotland website. Some key achievements are listed here on the slide, and we are especially proud of our work around the Getting to Know Me document, the involvement of family carers during a hospital admission, reducing the movement of people with dementia between hospital wards, improvements to the environment in the hospital setting, and supporting patients with dementia who experience stress and distress. We have also considerably influenced the implementation of legislation around the Adults with Incapacity Act. Since the start of the pandemic, the role of the nurse consultant has had to adapt to changing needs. We have responded to the crisis and ensured that the needs of people with dementia have been supported. We have provided information and resources, which has included the development of a specific information leaflet about coming into hospital with COVID, as well as introducing virtual visiting. We have supported the care home sector in Scotland by providing specific advice and guidance, as well as contributing to ethical decision-making groups. The next stage of our presentation will focus on the role of a dementia lead nurse in NHS 24, and I will now hand over to my colleague Tilda, who will describe her work.
Thank you, Helen. As the newest Alzheimer Scotland dementia nurse, I hope to demonstrate the value of my role at NHS 24. NHS 24 is a relative new kid on the block within NHS Scotland. Established in 2001 to initially provide an out-of-hours nurse triage system, as a 19-year-old it has matured into a vital service. The out-of-hours 111 service continues alongside a number of telephone and internet-based services to provide evidence-based care and healthcare information to the population of Scotland. These services have developed in response to the changing needs of our population. The latest development has been the COVID-19 advice line, which has provided advice, nurse triage and test appointment bookings. This has helped reduce the spread of COVID by avoiding the need for patients to visit their GP surgeries. Within NHS 24, my role has been to raise dementia awareness among staff. This has been done through awareness days, training sessions, and the development of a promoting excellence-based module reflecting the skills needed for telephone communication. I work collaboratively with the organisation's 5 dementia champions in identifying improvements in the way we provide our care to people living with dementia. One of the aims of Scotland's National Dementia Strategy is to reduce unnecessary hospital admissions. Increasing the knowledge and skills of our triage nurses should help ensure that only appropriate referrals are made to secondary care. I contribute to NHS 24 social media channels to support awareness levels with the general public. I also have a role of providing advice and support to employee carers and contributed to our employee carer policy. As a relatively new service provider, many people are unaware of the services beyond 111 that NHS 24 provides. By attending conferences and events, I've been able to direct people living with dementia and their carers to the additional information and support available. I've also been able to listen to their feedback about our services and take it to the organisation. As a nurse recruited externally to NHS 24, I was unaware of the full role that they play, as are many of my health and social work colleagues. With presentations, event attendance and social media, I've worked to raise awareness of how NHS 24 can complement their services, and particularly how NHS 24 is providing support out of hours and how information sharing can improve the care that NHS 24 can provide. I hope to have closer collaboration with colleagues in the future. As a member of the Alzheimer Dementia Nurse Consultant Group, I believe I have added an additional dimension to our national approach. I believe that the role improves NHS 24's ability to serve people living with dementia and their carers in Scotland.
Thank you, Tilda. So this presentation has highlighted the benefit of having an Alzheimer's Scotland dementia nurse consultant or lead nurse in each health board. The tripartite approach from Alzheimer's Scotland, Scottish Government and the health boards has been significant in the success of the role. The close working relationships with dementia champions and dementia specialist improvement leaders adds to the success of the role, as do the 4 domains of the nurse consultant. And Tilda, in her role, has highlighted the benefit of a dementia nurse in NHS 24. We hope you found this presentation useful, and we are keen to answer your questions. Thank you.
Thank you very much, Helen and Matilda, for this interesting presentation. I think you can be very proud with what you have achieved the last 10 years with this dementia special nurse. There were already 2 questions on the chat. One was already answered by Helen, that this project is not linked to the joint action called Act on Dementia and led by the Scottish Government. That was an easy answer. But there was another question to you from Emma Wolversen. She's writing, it is just a nursing role. Would you ever consider allied health professionals for this role and what they might add? And another question from Christina Magnetta. What are the qualifications of the nurse consultant? Can you answer this question, please, Helen or Matilda?
Yeah, certainly. So, so when the posts were first appointed to, they were all nurses that were appointed into the different health boards. Separately, there was a project that was funded by Scottish Government to have allied health professional consultants. So we did have 3 across Scotland who had a remit to the health board where they worked, but they also had a national remit. Out of those 3 posts, there's just 1 left now who works in NHS Greater Glasgow and Clyde. But just recently, actually just within the last kind of few weeks, the post in NHS Dumfries and Galloway was vacant, and it was advertised to be either a nurse or an allied health professional, and it is an OT who has been appointed to that post. So we are predominantly nurses, and it is just new, kind of hot off the press, that we will have an OT that will be joining the group. Which is great because, you know, we all work closely together anyway. The second question about the qualifications of a nurse consultant. The nurse consultants are predominantly all educated to at least master's level. So they've all undertaken postgraduate study, and some nurse consultants are now starting to work towards their PhDs as well. So they are all posts that have got quite extensive kind of clinical experience, but also backed up with academic study at either master's level or doctorate level. And we all have an academic home as well. So we all have honorary positions with universities local to our health boards where we all work as well. So we do have quite close working relationships with the academic institutions in Scotland as well.
I think that's quite different in the different countries. How is the qualification level of nurses? So in Germany, we have some also academic nurses, but most of them are not academic nurses, and that seems to be very different in the different languages. We have another question from Catriona about the isolation as a result of COVID has impacted people with dementia in terms of hastening deterioration. That's a very difficult word for me, deterioration in English. How do you see your role contributing to facilitating visiting in a safe way as possible for patients who are in hospitals long term?
Yeah, so obviously in Scotland, we have had open visiting. So it was a thing that's been introduced over the last couple of years, where we didn't have any restricted visiting times at all. So friends, relatives could visit patients in hospital at any time. So the old traditional set visiting times had gone. And that was just fully implemented across Scotland just before the pandemic started. And obviously when it did start, we very quickly went to stopping all visiting completely, which was obviously for people with dementia in hospital, it's a difficult enough experience, even when family can come and visit, but to cut off all communications and you know, face-to-face visits from families was obviously very distressing for people with dementia. So we were very concerned about that. So what we did, we've introduced virtual visiting. So we have iPads, you know, kind of tablet devices that have video calling facilities on them, either kind of FaceTime or Google Duo or Skype, so that we can keep those connections, albeit virtually. And that's been fantastic at helping to kind of keep connections for patients and for visitors. And it's not just obviously for people with dementia, it's for all patients that are in hospital. In Scotland at the moment, we have started to reintroduce hospital visiting. So it is quite controlled. It is a set named individual that is allowed to come and visit. Obviously this is, you know, varying at the moment, because we've got some parts of Scotland that have gone into kind of more restricted measures at the moment. So visiting has had to kind of be withdrawn again in some areas. But we are kind of working really closely with families to support visiting as much as we can. Throughout the pandemic, even when all visiting was stopped, visiting was still allowed in specific cases. So people end of life was still allowed visitors, and people that where distress was so much that it was causing more harm by not being able to have visitors, we have supported relatives to come in, and that quite often has included people with dementia, that if they are that distressed, then we will support visitors to come with all the kind of PPE and infection control measures in place to allow that.
Do you think some of this virtual contacts maybe will be kept even after the pandemic? If I look to your card of districts, I see, for instance, the Highlands, it's very rural and far distances.
Yes, I know that the virtual visiting that we've set up, the use of iPads and tablets, the nationally Healthcare Improvement Scotland are working with all health boards across Scotland for all health boards to implement this, and this will be something that we will keep going forever, because, you know, we have people in hospital who maybe have family down south or abroad, so it means that we can keep connections even when, you know, hopefully normal visiting returns. We can still use this technology to keep patients connected with family that maybe aren't able to visit because they live further afield. What we've also done with the devices is we've downloaded interpreter apps onto them, translator apps. So it means that wards have 24/7 access to interpreter services, which is great as well. So that is something that will continue forever after the pandemic. So although it's not something we wanted, we want visitors to be able to come in person. Having the iPads to allow virtual visiting has been something that has been great, and it's something we can continue to do even after the pandemic is hopefully over.
Okay, thank you very much, Helen and Matilda, first for your presentation, but also for answering the question. There's another comment in the chat and with a link. Thank you for Julie for this link about the work in dementia in hospitals in Scotland. So thank you so far. And we are going from Scotland, we are going now to Denmark. And I really like to welcome Anders Møller Jansen from Denmark, and he will do a live presentation. So hopefully everything works fine. Welcome, Anders. You are from via University College in Holstebro. Maybe you can explain where it is in Denmark, and you are a researcher on one side, but also you are a supporter for a person living with dementia of the European Working Group in Denmark, and you're speaking about nurses' experiences of delivering acute orthopedic care to patients with dementia. So the floor is yours. Thank you.
Thank you very much, Sabine. So thank you to the Alzheimer Europe for giving me the opportunity of presenting the last piece of my PhD studies empirical work. So we're going to look at some of the nurses' experiences of delivering acute care for patients with dementia, specifically in orthopedic wards. So just to give like a short introduction to what is sort of like one of the main topics that I focus on in terms of hospital care, and just overall to put it in perspective, I always refer back to the OECD 2015 presentation and try and look at some of the figures that we have down here highlighted in red, that hospital cost is 3 times higher if a person also have dementia. And sort of like the benefit they get of going to hospital is actually quite reduced to care compared to a normal patient going into hospital. So we spend a lot of money on patients with dementia going to hospital, and they gain too little from it. And that was one of the curious questions that I would like to focus on in my PhD study. So just overall, to give an introduction of what does nurses, how does nurses view caring for patients with dementia? And that's a topic that's been covered in a lot of papers, and it'll draw too far to go through all of them now. So I'll just try and sum it up by using this quote from Fiona Cowdell's also PhD work, say that, just summarizing up, and that's how we do it. We treat them all the same. And knowing a bit about a patient with dementia and their needs in terms of person-centered care and a more holistic approach to them, know that we are basically heading into trouble now if that's the way that nurses are actually viewing caring for patients with dementia. So the aim of my study was to investigate nurses' experience of caring for patients with dementia who are recovering from an orthopedic surgery in an acute ward hospital setting. A lot of studies has actually been done generally, or maybe more focused in medical wards in terms of looking at what are our experiences of caring for patients here. So I specifically choose looking at orthopedic wards in order to try also and get that side, and maybe through my work see if some of my results are different from what you would experience in some of the medical wards. So the method that was used in this part of the project was a qualitative interview conducted with nurses who were working at orthopedic wards, especially focusing on their experiences of caring for patients with dementia. So they were allowed to use their experience sort of like from a work-life experience working at a ward, and not just specific incidents. Methodologically, a phenomenological and humanistic approach inspired by recursive theories about narratives, interpretation, and structure and analysis were used in working through the data. So this technique enables the researchers sort of to still the most meaningful and important of a phenomenon that is under investigation, in this case, acute dementia care in orthopedic wards. Just very short about the participants that was in this study. 8 nurses was invited and also accepted participating in this interview. The nurses have, all of them had various skill levels, or at least level of experience in working at a nursing group, working at the hospitals. Some of them have been there for quite a few years, and some of them had years and years of experience. And this interview session that I did with these 8 nurses was a follow-up of a very intense participant observation period that I have been conducting at this ward. So maybe some of you are aware that last year I did a presentation also about the patient's experience at being at an acute ward and having Alzheimer's disease. So just to sum it up a little bit, I did very intensive observation of only one patient at a time. So I was there from admission to discharge, and I was there as many hours that I could cover in one day. That meant a lot of hours at the work. That meant a very deep insight into how nursing practice was done, particularly in this ward. And it also meant that the nurses that I was interviewing, they knew that I know what was actually going on. And it helped the dialogue a lot, because it made it very intimate in terms of they could refer back to things that I had seen. And I also had the opportunity of maybe sort of like figuring out, well, what I saw in my participant observations, how does that reflect to what they're telling me now in the interview sessions? So these things are interlinked, and of course also my observations inform the questions and the things that I would like to talk with the nurses about. So the results, just very overview-like, is two main themes emerged from the analysis that we conducted. One was nurse communication and patient information, and the other one was care compromises done through the intervention. I'll go through them now shortly. So, under nursing communication and patient information, one of the first things that the nurses mentioned to us was that they found it difficult to conduct a care for a patient with dementia, because a lot of the information that was needed for them actually drowned in the electronic patient journal. So the nurses that have worked with the patient before very meticulously wrote down note of what happened and how did I try to solve problems. But since the journals very often are read chronologically, important information may very often be very down far a page that nurses will not read up to. And especially on day 3 and day 4, the nurses pointed out that the electronic patient journal became so long that you just didn't bother reading more than 24 hours back. So performing a care for a patient with dementia has the challenges of the way that this electronic patient record was set up was not sort of like highlighting specific areas that was of interest with this patient, but more chronologically showing everything that had happened in terms of care and other tasks at hospital. So that was one challenge that was mentioned very frequent in the interviews, that the journal did not really support them. So the way that staff tried to mitigate that was actually sort of circumventing the system and making oral handovers of patients among staffers, even though there was actually no time set up for that in the shifts. And they also made small paper notes that they handed out to each other in order sort of like to make a distilled description of what is actually the basic areas that we're working on with this patient. But it's not really a viable solution actually, and it becomes very limited when it's just a piece of paper that's being handed around. Another topic that also showed up was that nurses definitely did not find hospital environment suitable for the patients with dementia. Some of them said that ideally that should go directly from the operating table and home. That's maybe a bit of a far stretch. They know that as well. They need the care that the ward can provide to them. But it also says a bit about what we'll look at later, some of the discomfort that the nursing staff have of caring for this group of patients, that they actually rather want them to go somewhere else than have them at the orthopedic ward. I also tried sort of like to broaden the question a bit when talking about hospital environment in terms of could it be other things than just a layout of the ward, maybe for instance activities performed there or knowledge that the staff had. And it actually always reverted back to questions about layout and design, sort of like trying to avoid talking about competences in other forms than just what was sort of like physically laid out in the environment. We'll come back to that a bit later on. So another topic that was also very prominent among all the nurses interviewed was that somatic clearly has a priority. So a lot of orthopedic tasks is being very much focused on them. So all the things that you would expect an orthopedic ward would be very good at performing are the ones that they mention. And in a clear second place, they'll name everything that has to be alleviating stress for the patient and trying to make them comfort and accommodate some of the more holistic approaches to a patient. So there was a very clear distinction here between what is actually has priority. And it is this point during the interviews that sort of like the storylines tends to split into two, where the group of nurses interviewed were not really all that agreeing. So one group of them would give examples of activities or ways to approach a patient with dementia that would try and comfort them, whereas another group of them would be more or less oblivious about whether it was actually possible to do it or whether there was any means for it to do it. As one of them said, the priority is to give the patient the right medication. Whether they get milk in their tea or not has nothing to do with us. So they also, some of them was not very open to the idea of looking into the patient's life history. That could have been done with reaching out to the nursing home. But some of them found that they simply didn't need to do it because the patient was typically only at hospital for a few days. As my data previously showed, that's not always the case. So going on to the second main theme and looking at some of the topics that went out there. The first one was about variation to the standard care regime. So an orthopedic ward, and I guess any ward, does have a sort of like a standard package that they are trying to improve because that was the best method they have found out to help, for instance, a person with a broken hip. So this standardized care regime is very well known to the nurses, and they act on it so like they have never done anything else. But the problem happens if a patient with dementia cannot apply to this because of some of the conflicts that they have with their dementia disease. And this actually reverts back to the first topic that we had of drowning in the patient journal, that staff does actually not know when they are handed a patient to care for these 8 hours during this next shift, whether there are any specific areas that this specific patient that we need to address in deviating from the standard care regime. Which means that staff actually, first of all, try and retry to keep up the standard care regime, and it makes them very stressful. As one of the staff puts it, if I have a patient and I'm doing 5 tasks with her in one day and I fail, sort of half fail one of them, I can live with that. But if a patient has dementia and I'm doing 5 tasks with her in a day, I'm basically failing all 5 of them. And that I cannot live with professionally. So it raises sort of like a huge doubt in terms of when am I allowed to deviate from the standard care regime. And it also brings back guilt into the equation when some of the staff are sort of like, if I decide not to get the patient out of bed, she might call pneumonia, and then I'll get guilty for was it things that I did in my shift, that meaning now the patient has further complications. So it actually gets very complex for the nurses in order to figure out how and when I'm allowed to deviate from the standard care regime. I also asked the nurses if they felt any pressures from the doctors to stick on the standard care regime, but that was actually distributed very simply. Said if we recommend to the doctors that we deviate from the standard care regime, we're always allowed to do it, but we don't know in which cases that we actually is a good thing to do it. So there's a bit back and forth here between things missing in the patient journal and also a focus on what is actually in what are we actually working on specifically with this patient. This, some being more in doubt than others, led into a discussion where the nurses started talking about what is sort of like the ideal nurse of caring for a patient with dementia. And they, for themselves, pointed out that a nurse being calm around the patient and also being very adaptive here, reflecting back to the standard care regime, was some of the things that the nurses pointed out was very important in terms of delivering the best care to a patient with dementia. So it very much points to that the nurse's personality is brought into play here, because as the nurses put it out themselves, some of us run in and out of the room all the time, and others are better at staying with the patient and getting to know them and getting to know them a bit better in terms of what their care needs are. So it actually turned out that there was sort of like a hidden distinction in between the nursing group of those who know for themselves that they are excelling in terms of doing care for patients with dementia, and the ones who define themselves as novices and are not very comfortable in terms of doing care to a patient with dementia. And this was not something that I saw during my participant observation, that it was very clear to all nurses, sort of like, which group are you in? The ones who define themselves as good as caring for a patient with dementia, or the ones who definitely would rather avoid it. So it's an unspoken, and it's actually a hidden division among the staff. And I can tell you it's not sort of like 50-50. The nurses describe it more like possibly only 20% of the care staff does actually find caring for a patient interesting. This is a quality study, so don't hang it in the numbers, but it just showed that it's very few of them who actually fulfills this role of being calm and adaptive. And it also led to a discussion of, so what's actually happened if you apply a nurse who do not live up to these principles of being calm and adaptive to a patient with dementia? And it was reported that by some of the nurses who also do the planning of who's taking care of who, that she said that I feel sorry for both the patient and for my colleague if that has to happen. But the schedule has to fit for some reason. And it's not always taken into account when you do the planning of who's on shift, who does actually have the competences of maybe caring for a patient with dementia, even though a lot of them know it, but it's just not spoken of, and it's maybe also very difficult to plan ahead. So,
Anders, just to let you know, our fourth speaker has arrived, so we need some time for her too.
Yes.
Thank you.
I'll finish it up. So it's very clear that a lot of the nurses actually find it very difficult to care for these patients with dementia. And this raises sort of like a preconceived idea that patients with dementia are difficult to care for. They basically at one point calls them a nuisance, but they know that they have to stay here. So we are doing our best to care for them. And it also raises a lot of frustration, because when trying to perform care for a patient with dementia, if you're in a group or if it's your own experience that are not really good at it, makes you feel vulnerable and insecure. And as one of the nurses says, it's like a dog chasing its tail. I became insecure, and then my competence level dropped, and my care never will rise from here. It also raises another question to some of the nurses who actually was good at or defined themselves as relatively routine at performing dementia care. But what are your experience in terms of your colleagues trying to also learn something? And there was very little willingness in terms of moving from one group to another. That's just a short way of describing it. Since we would like to give room to another speaker, if you are interested, you can read a lot more about this study, because it has already been published in the International Journal of Older People Nursing. So you can find it there. And to my big surprise, it actually won a student award for outstanding methodological innovation in ecological nursing research. That I did not see coming. But if there's any question after any time for it, I'm open.
Thank you, Anders, for this interesting presentation about your research, and congratulations to the award. There are already some questions in the chat. We will try to answer them in a maybe short way. There's one comment from Joey. She writes that she, as a nurse, is horrified by that 2010 quote, goes against everything we are taught about person-centered care. That's just a comment. Maybe you want to answer it, but I also add the comment from Matilda, who was one of the speakers before. She writes, I work with elective orthopedic wards, and people with a diagnosis of dementia manage very well with the extra support identified pre-admission. It is people for whom admission has shown light on cognitive problems. And another question from Caroline. So interesting, what factors impact on staff in acting their value, stigma or something else? Maybe you can give a short answer to these comments or questions.
Yes, if we start with the 2010 quote, it's certainly not the nurse's interest of acting in that way, but the lack of knowledge and the way that hospital routines are structured basically forces them into doing it. So it was very clear, and I go more into deep that in the article, that the nurses does definitely not want the situation to be like this, but they can't find a way out because the whole concept of making a dementia-friendly hospital hasn't started at that point when I did this study and this observation. Mm-hmm. So, and regarding to the question about preparing a patient to going into hospital, we can make it a lot better. I completely agree about that. But that was specifically why I choose an orthopedic ward, because you don't plan on going to a hospital with a broken hip. It happens every day. And that's why it also becomes very important of understanding this type of hospital admissions and how to deal with them a bit better than what is being performed now.
Okay, thank you very much. There's another question for Catriona in the chat. Maybe you can answer her directly in the chat, yes, because I would like to hand over now to our last speaker. It's Ioana Jankio. Maybe you tell us how you pronounce your name. Ioana, you are from Romania, Bucharest. And first of all, we have the pre-recorded presentation about before the end of life in patients with Alzheimer's disease.
Good afternoon, dear colleagues. Here is our presentation, Final Stages in the Journey of Life for Patients with Alzheimer's Disease. So, the quote of our presentation is, "A soul claims its right to a many stars body. The ways of the body should match the ways of the soul. If not, they break apart at the crossroads. One remains and fades out, the other goes to its eternity. No man would want to remain a greenhouse barren fruit. Only this way he accepts his death as a temptation, gentler, less terrifying." Today, in developed societies, there is a talk about deathless generations. The individual is born, gets through childhood and adolescence, becomes an adult, gets married, and gives birth to children. All along this period, he does not face with death in his own family. The modern man considers death a strange phenomenon of the world he lives in, not a natural process or close to him. 80% of our patients with Alzheimer's disease with mortality is registered in clinics or care institutions, but not at home. People die with foreign faces, in foreign places, in foreign beds, with foreign people around, and with no people from his family to comfort them. We know people can live with Alzheimer's disease for years, 10 per 15 years, and it is hard to believe that this is a terminal disease. At the end of life, patients suffering from dementia can present special challenges for doctors and caregivers. Dementia's unpredictable progression includes some signs in the final stage. So, being unable to move around on one's own, being unable to speak or make oneself understood, needing help with most, if not all, daily activities such as eating and self-care, eating problems such as difficulty in swallowing. Our presentation is based on the excellent experience of the Geriatrics, Gerontologie, and Old Age Psychiatry Clinic within the ELIAS Emergency University Hospital of Bucharest, affiliated to the Carol Davila University of Medicine and Pharmacy Bucharest, in addition to the partnership with the European Alzheimer Disease Consortium. The clinic has a large patient database suffering from Alzheimer. Sick people is admitted in acute stages or are monitoring in the outpatient clinic, re-evaluated on an ongoing basis, patients carried at home or by the caregiver, as well as patients from nursing homes. In our experience, the base is the standardized geriatric evaluation, the stage, clinical, imaging, and genetic diagnosis is the first link in the broad chain, which is supposed to represent the multidimensional approach of the patient suffering from Alzheimer's. The evaluation allows the establishment of the diagnosis, treatment, and the approach of the future care of the patient as well. Any call at the geriatric clinic is an alarm signal. Because of their unique experience with what happens at the end of life, hospice and palliative experts might be able to help identify when someone is in the final stage of Alzheimer's disease or in the last days or weeks of life. In our experience, most of the people become calm in the last days. So the calm state during the last months of life, with small periods of coherent speech, articulate simple words perfectly and answer short questions. The word is simply, they say home. They cannot give details about that, but their answer is stereotypical. Another way is to see a nephew they raised. They do not recognize their spouse or children, but all of them wanted to recognize their nephew and wanted to speak with them. Another wish they express is to eat and to enjoy the preferred meal or a preferred drink. The caregivers emphasize this, and they tell us that they never heard such a thing until the movement of admission, but confirm that that is true. In this variant, in the last days, the patient is reconciled with a long suffering and dies quietly, calmly. Agitation. Delirium is a mental disorder that includes confused thinking and low environmental awareness. Delirium can often be related to one or more contributing factors such as severe or chronic illness, changes in metabolic balance, medication, infections, surgery, or alcohol or drug intoxication. Due to the fact that symptoms of delirium and dementia can be similar, family members and caregivers may greatly contribute to the accurate diagnosis. Here, it's a comparison between delirium versus dementia in this table. Behavior changes like hallucination, restlessness, agitation, or combative behavior, calling out, mooning or making other sounds, being quiet and secluded, especially in older adults, deferred movement or lethargy, reversal of night-day and sleep-wake cycle, and in our experience, the three types of delirium, hyperactive delirium, hypoactive delirium, and mixed delirium include all of them, but most. In our clinic database, the most frequent form of delirium is a hyperactive form. The diagnosis requires the participation of the multidisciplinary team, which comprises, along with the geriatrist, the psychiatry clinician, the clinician psychologist and the patient's high history provided by the family or the caregiver. The diagnosis is a true hard rock because there's never a single cause in the mechanism of vesperal agitation and of the reversal of the sleep-awake regeneration, sometimes by 75%. Possible causes: certain medications or drug toxicity, a medical condition, stroke, metabolic imbalances, severe chronic or terminal illness, pain, fever and acute infection, malnutrition or dehydration, sleep deprivation or severe emotional distress are some of the possible causes. Anesthesia. Possible causes are some several medications or combination of drugs can trigger delirium, including some types of painkillers, sleep medications, medication for mood disorders such anxiety and depression, steroid medicine, and Parkinson's disease drugs. The fourth variant in the evolution of the terminal patient with Alzheimer dementia is the association of some comorbidities that have demolished the old pathological perception from literature. Today, we meet more and more often the sepsis triggered by urinary infections, pneumonias, rectal and gynecologic pathologies. In the last 2 years, oncologic pathology, colorectal cancer, urinary bladder cancer, cervix cancer was more frequently diagnosed in patients over 90 years old. The cardiovascular pathology, strokes, myocardial infarction, heart rate disturbances aggravate the evolution of the memory type pathology and speed up death onset by hydroelectrolytic and metabolic deprivations of patients of 4th and 4th age. The diagnosis is complex, requires extensive imaging, biologic and lab examinations, which in most of the times perform against the clock and requires the participation of multiple medical teams. In the end, quality of life is an important issue when making healthcare decisions for people with dementia. When making care decisions for an end-of-life patient with Alzheimer's, we consider the goals of care also for family and for caregivers. The place among the stars is one in the moment when us, the doctors, have established the diagnosis of this 21st century disease. Thank you for your attention.
Thank you very much, Ioana, for this interesting presentation of different aspects of the end of life. It's always not easy to define the late stage or to define comorbidities or find the difference between delirium and dementia. So at the moment we have no questions to you in the chat. So I like to thank you for the presentation so far, and because we are at the end of the session, I like to thank all presenters for their speeches. We have arranged from a special village in France to the very good work of nurses in Scotland, a research in an orthopaedic ward in Denmark, and at the end we came to the end of life in Bucharest. So thank you so much, and also I like to thank all the participants who were joining us in the chat and were commenting in the chat, and so I appreciate very much that you was so active in the chat and all interesting, have so many interesting speeches. Have a nice day. Join other interesting speeches, and see you maybe again in Bucharest. That's the place of Ioana at the last. So see you maybe in Bucharest next year. Have a nice day. Bye-bye.